Welcome everybody to the MIDAS webinar for October 2024. It's our pleasure to have Dr. Sarita Bugalia to speak to us today. Dr. Bugalia is a postdoctoral research associate in the School of Animal and Comparative Biomedical Sciences at the University of Arizona. I don't think I've heard of a school with that name before, but so that's fascinating in its own right. Dr. Bugalia received her PhD in mathematics from the Central University of Rajasthan in India. Her research interests lie in infectious disease modeling, where she employs analytical and advanced simulation techniques to elucidate and enhance understanding of the dynamics of both emerging and re-emerging diseases that are of significant public health concern. And so the talk today is going to be on mutations in SARS-CoV-2 variants and imperfect vaccination. So I encourage folks, if you come up with questions, please put them in the Q&A and we'll have some time afterwards. But with that, I'm going to hand it over to Sarita, and we're looking forward to hearing what you have to say.
Thank you so much, Harry. It was a nice introduction. Can you see my slides?
Yes, they're fine.
Okay. So, hello everyone. Good morning from Arizona. It's 10 a.m. here. So, I am a postdoctoral research associate in the School of Animal Comparative Biomedical Sciences at the University of Arizona. And today, the title of my talk is Mutations Make Pandemics Worse or Better, Modeling SARS-CoV-2 Variants and Imperfect Vaccination. So today I will talk about a mathematical model for the viruses like that mutated over time. For example, so specifically for the SARS-CoV-2 that mainly caused the disease COVID-19. And I will also consider the mutation rate and the vaccine in the model because the vaccine is available for the COVID-19. But first, I will talk about mutation. So in the past, there are many viruses happened that incline to mutation. And mutation is like the viruses mutate over time because of in their genetic variations. So they change their in their DNA and RNA to persist in the population or in the environment. And it is mainly because of the racist human attacks of the host and induced by the treatment of the antiviral drugs or antibodies. So, for example, this study confirms that the HIV-1 virus can develop resistance to the antiretroviral drugs in blood and in both blood and plasma. And another study confirmed that about the another virus, the hepatitis B virus, that this virus can also mutate because of its high replication rate. And this study the another study confirmed that there are many variants exist of the influenza virus, and there are many other viruses happens. For example, West Nile virus, measles, dengue, because there are 4 different serotypes exist of the dengue disease. But in this webinar, I will specifically talk about the COVID-19. So, in the last 4 years, the COVID-19 happened, and COVID-19 is also a respiratory disease that caused by an RNA virus called SARS-CoV-2 that is inclined to mutation. And in the last 4 years, there are many different variants happens of the SARS-CoV-2 appeared. And there are many different, so WHO gave name to the name many variants like variant of interest and variant of concerns. So these are the variants of interest of the SARS-CoV-2. For example, epsilon, zeta, eta, theta, iota, kappa, and lambda. So epsilon variant of interest first appeared in the USA in March 2020, and Zeta variant appeared in Brazil in April 2020, and Eta variants appeared in multiple places in 2020, and Theta variant appeared in Philippines in January 2020, and Iota variant appeared in USA in November 2020, and Kappa variant appeared in India in October 2020, and Lambda variant occurred in Peru in August 2020. So these variants of interest are like these are less protective against vaccination, and they can also develop ultimately to the variant of concern. But these variants did not lead any outbreak. But these are the concerned variants. So WHO named these virus, and now we will talk about the variant of concerns of the SARS-CoV-2. So there are five different variants of concern appeared of the SARS-CoV-2. For example, alpha variant appeared in the United Kingdom in September 2020 and led an outbreak and a big outbreak in the UK. And beta variant appeared in the first time appeared in South Africa in May 2020 and led a big outbreak. Similarly, the gamma variant appeared in November 2020 in Brazil, and Delta variant appeared in October 2020 in India, and there are many cases happened in India because of this variant. And Omicron variant first time documented in South Africa in November 2020, and the Omicron variant spreaded all over the world and led outbreaks in every country. So these are like the variant of concern and led big outbreaks in every country. And in this study, I will propose a mathematical model specifically for India. So in India, there were variants of concern of the SARS-CoV-2. So in India, in January 2020, so now these variants of concern, the last variant of concern appeared in 2021, and after that there is no variant of concern. But now there are more than hundreds of variants of the SARS-CoV-2 exist, but they are not making any outbreak. And I think the disease, COVID-19 disease, become an endemic disease in the population because there are now many cases happening, but there is not any outbreak, and there are many disease-related deaths happening all over the world. So in India in January 2021, there was one alpha variant, 5% cases of because of alpha variant, and the other 95% cases of because of another small variants of the SARS-CoV-2. And then in February 2022, the alpha variant was emerging, and the cases were 11%. And then in March 2022, the another variant of concern appeared. The name of that variant is Delta, and the cases were rising because of this variant. And in April 2021, there were 62% cases because of this Delta variant. And then in May 2021, we can see there are 94% cases because of this Delta variant. And then in December 2022, there are the Omicron variant appeared, and 20% cases because of Omicron variant. And then after January 2022, there was a big outbreak because of this Omicron variant. So mutations sometimes can be harmless, sometimes can be harmful, and sometimes we can see there is no impact of the mutation because these like Omicron variant is more transmissible, like it can spread it all over the world. And like we can see there are many variants of the SARS-CoV-2, they are not making outbreaks in the population. So here we can, these are the daily new cases of COVID-19 in India. So we can see from March 2021 there was Delta variant, and there was a big outbreak because of the Delta variant. So in this outbreak there were two variants, for example alpha and delta, and there was a big outbreak. So I will apply the model for the COVID-19 cases in India for this outbreak, and I will consider two strains of the model, namely the alpha and delta variant. So the objective behind the study are, we want to construct an epidemic model that describes the dynamics of two strains, namely the native and mutant strain, and also an imperfect vaccination for the COVID-19. And then I want to study the impact of the vaccination efficacy and mutation rate on the disease burden. And then I want to investigate the different bifurcation. Bifurcation means there is if we vary a certain parameter of the model, then there is a sudden change in the behavior in the disease dynamics. So I want to study like if there is any bifurcation occur in the model, with respect to significant parameter, for example, mutation rate, because we are considering two strain in the model, so mutation rate is a key parameter in the model. And here is the multi-strain model. So to develop a mathematical model, we divide the total population into different compartments. So let us suppose the total population is n. So in this model, we divided the total population into 8 different compartments based on the disease characteristic and the control intervention strategy. So first we divided the total population into susceptible compartment, and then we have considered the vaccination in the model. So we have considered the vaccination compartment. And then for the COVID-19, we know that there is a latent period of the disease. The average latent period is 14 days. So in this period, the individual can develop the disease, but sometimes the individuals cannot transmit the disease to another individual. And after this period of time, the individuals enter to the infectious compartment. In this model, we have considered two strains, namely the native and mutant. So here even represents the individuals that are exposed to the native strain, and E2 represents the individuals that are exposed to the mutant strain. And I1 represents the individuals that are infectious to native strain, and I2 are the individuals, sorry, I2 are the individuals that are infectious to mutant strain. And R1 and R2 are the recovered individuals from the native and mutant strain respectively. So in this model, we have considered a recruitment rate lambda, and the natural death rate mu is considered in every compartment, because every a diseased individuals can also die from the natural death rate. But we are assuming that every individual via birth or immigration rate that are joining the susceptible compartment only. And then we consider a vaccination rate. The vaccination rate is given by P. So at this rate, the individuals are moving to the V compartment. The susceptible individuals can only, we assume that the susceptible individual can only get the infection, and at this rate, these individuals are moving to the vaccination compartment. After that, the susceptible individual can get the infection from both the native and mutant strain. So we assume that the beta 1 is the transmission rate in the susceptible individual because of the infectious individual that are infected by the native strain. And beta 2 is the transmission rate between the susceptible individual and infectious individual that are infected from the mutant strain. So these beta 1 Si1 are the infected individual from the native strain moving to the E1 compartment first, and these exposed individuals are then moving to the infectious compartment at the rate A1. And the susceptible individuals are moving to the compartment E2 at this rate beta 2, and beta 2 Si2 are the incidence, or we can say these are the number of individuals that are moving to the E2 compartment. And then from the E2 compartment, A1 and A2 are the infectious rate. So at this rate A2, these individuals are moving to the I compartment. But we know that the vaccine is imperfect because vaccinated individuals can also get the infection from both strains, but at a reduced rate because they have some immunity inside the host because of the vaccine efficacy. So we assume that vaccinated individuals are moving to the compartment E1 and E2, but at a reduced rate. So here we have multiply a parameter delta. So delta lies between 0 to 1. So this parameter is reducing the transmission rate B1. And we can say is the 1 minus delta 1 here is the vaccine efficacy. Because if we consider delta 1 is equal to 0, that means the vaccine is 100% effective. That means no vaccinated individuals is moving to the E1 compartment. And if we assume that delta 1 is equal to 1, that means vaccinated individuals are moving to the E1 compartment similar to the susceptible individuals. That means there is no vaccine efficacy. Similar interpretation can be concluded for this transmission rate. And then D1 and D2 are the disease-induced death rate of the infectious individuals, and alpha 1 and alpha 2 are the recovery rate of the infectious individuals. And in this model, we have also considered that the recovered individual from the native strain can also get the infection from the mutant strain in later time. But these individuals have some immunity against the mutant strain. So they can get the infection at the rate beta 2 because beta 2 is the transmission rate because of the mutant strain. But here delta 3 we have a reduction parameter or reduction coefficient in the transmission rate. So we can say 1 minus delta 3 is the immunity parameter, immunity gained from the infection from the native strain. And we have considered a mutation rate, new one here. So mutation can happen in the inside the body of the host. So infectious individual from the native strain are directly moving to the infectious individual to the mutant strain because there is one variant occurring in the host. So these individuals are moving from I1 to I2. This is the flow diagram of the model, and based on this diagram, these are the differential equations of the model. So we like this flow diagram is representing this model, and then we have considered the non-negative initial conditions of the model. Now we have done some analysis of the model. So here I'm presenting a smaller part of the analysis. So first we have computed a disease-free equilibrium. So disease-free equilibrium is a state in the system where all infection die out. So to compute a disease-free equilibrium for the model, we just have to put all the infected compartments is equal to 0 and the non-infected compartment not equals to 0. So this is the expression of the disease-free equilibrium, and these are the number of susceptible individual at the disease-free state, and these are the vaccinated individuals at the disease-free state in the system. And then we have computed a basic reproduction number of the model by considering the next generation matrix method. So because in this model we have considered two strains, like the native strain and mutant strain. So basic reproduction number is gives the idea of the secondary cases generated by a single infectious period in her or his entire life, infectious lifespan. But there are two types of infected individuals, native and mutant. So both individuals are generating secondary cases. So the basic reproduction number is given by the maximum of R1 and R2. And R1 is the basic reproduction number associated to the native strain, and R2 is the basic reproduction number associated to the mutant strain. So if the maximum of R1 and R2 is equal to R1, then the outbreak will led by the native strain only. And if the maximum of R1 and R2 is R2, then the outbreak will led by the mutant strain. And here we have computed the basic reproduction number of the model without vaccination, because we want to compare, and later we will compute expression of herd immunity. So we want to compare the basic reproduction number with vaccination and without vaccination. So in the model, P is the vaccination rate and delta 1 and delta 2 are the parameter related to vaccine efficacy. So we just put these parameters is equal to 0. Then we have computed this basic reproduction number. This is the maximum of R1WV stands here for the without vaccination. So the maximum of R1WV and R2WV, and here R1WV and R2WV are the basic reproduction number associated to native and mutant strain only. So here we have some results for the model. So we have analyzed that if the basic reproduction number is less than 1, then the disease-free equilibrium is locally asymptotically stable. Otherwise, it is unstable. So the disease-free equilibrium is locally asymptotically stable means if the basic reproduction number is less than 1, then the disease will die out from the community. And locally, so there are two types of stability, the local stability and global stability. Local stability means if the population is in the close neighborhood of the disease-free state, then the disease will die out. Or we cannot give the guarantee of the global stability. So we have this result. And then we have computed the mutant dominant equilibrium. So this model is very complex model, so we do not have any explicit expression of the mutant dominant equilibrium. So for the mutant dominant equilibrium, we have the equation of the model. So for the mutant dominant equilibrium, we have to say like the native strand should die out from the population. Then the mutant dominant equilibrium exists in the system. Then for this equilibrium, we have to assume that the basic reproduction number associated to native strand should be less than equal to 1. Then the native strand die out, and the basic reproduction number associated to the mutant strand should be greater than 1. So then the mutant dominant equilibrium appear, and then since we do not have an explicit expression, so we directly prove the global global stability of the equilibrium, and by constructing a Lyapunov function. So and we knew that there is a Lyapunov function exist of the stability of this equilibrium. That means there is a unique equilibrium exist for the model. And by giving some numerical value of the parameter, we can compute a mutant dominant equilibrium, but we do not have any explicit expression of the equilibrium. And then later we have analyzed a coexistence equilibrium of the model. Since computation of coexistence equilibrium is more complex, because in the model, every variable should be not equals to 0. So that we have directly analyzed that the equilibrium is globally stable, but only this special case. For example, delta 3 is equal to 0 and nu 1 is equal to 0. So here nu 1 is the mutation rate and delta 3 is the parameter related to the immunity against to the mutant strain. That recovered individual from the native strain already gained some immunity against the mutant strain. So we have found out that there is a Lyapunov function exists for this equilibrium. For this special case, then this equilibrium is globally stable. That means there is a endemic equilibrium exists, and these from the model we can conclude that the native and mutant strain can coexist together in the environment. But then we have to analyze what if these parameters are not equal to 0. Then we cannot compute by mathematically, but numerically, if we give some values, then we will analyze some different kind of dynamics in the model. Then we have computed an expression of the herd immunity. So to eradicate a disease from the community, not every person needs to immunized. So a fraction of population with required immunity in a with required immunity can eradicate to the disease, and that is called the herd immunity. So based on this model, we computed an herd immunity basically because of the vaccination, and because we have considered a vaccination in the model, we did not consider any natural immunity or any kind of another immunity. So here P in the model, here P is the vaccination rate. So this is the fraction of the vaccinated population at the disease-free equilibrium. Then from the expression of the basic reproduction number, we can write the basic reproduction number is this in this form, where R1WV and R2WV are the basic reproduction number without vaccination, and 1 minus delta 1 and 1 minus delta 2 are the vaccine efficacy, and here rho is the fraction of vaccinated individual. And since we know that when the basic reproduction number is less than 1, then the disease will die out. So R naught less than 1 is a necessary and sufficient condition for the eradication of disease. So from this condition, from this inequality, we can compute a critical value of this fraction rho. And this rho critical gives the expression of the herd immunity. So from here, we can see that if this parameter is greater than rho critical, then this is also a necessary and sufficient condition for the disease elimination. So this expression is for the herd immunity. So if a population gains this herd immunity, then the disease will die out from the population. Then we have analyzed the impact of vaccination rate. So we have computed a derivative of the basic reproduction number with respect to the vaccination rate, and we have seen that the basic reproduction number with respect to the derivative of the basic reproduction number with respect to vaccination rate is less than zero. That means if we increase the vaccination rate, then the basic reproduction number will always decrease. It's a decreasing function of p. That means if we want to minimize the basic reproduction number, then we have to decrease the vaccination rate. And we have also computed a critical value of the vaccination rate. So if the vaccination rate p is greater than this critical value of the vaccination rate, then disease will die out from the community. And then we have done a case study on COVID-19 in India. So we have collected the COVID-19 of data of COVID-19 from March 2021 to September 2027 of 31 weeks. This is because of we have we have already discussed that there were two variants. The Delta variant appeared in the starting of the March and led a big outbreak. So, and since this is a general model, this model can also applicable for the another like another country for different to native stream. But we have applied for the model to a case study in India. So from the model, the cumulative cases can be given by this equation because these are the infectious rate, and at this rate, individuals are moving to the reported cases. And these individuals, this equation gives the cumulative deaths because these are the disease-induced death rate of infectious individuals. So based on these equation, we have fitted the data of COVID-19 by using the Markov chain Monte Carlo method, and we have seen that these blue boxes are the data, and the orange curve is the model output, and this here time in weeks, and these are the cumulative cases. So we can observe that the data are like the model output is really close to the data. And this is the data fitting for the cumulative deaths also for 31 weeks. So this x-axis shows the time in weeks and y-axis shows the cumulative deaths, and blue boxes are the data of deaths, and the orange curve is the output of the model. And based on these data fitting and using the MCMC method, we have estimated these parameters. So some parameters we collected from the literature because we know the vaccine efficacy, we know the average lifespan of the model, and we know the incubation period of the disease. And some parameter we have assumed, and some parameter. So we have estimated the transmission rate mainly, and the recovery rate, and the mutation rate, and the disease-induced death rate because we have considered the cumulative deaths. And then based on these parameters, we have analyzed the impact of the parameter specifically for vaccine efficacy and the mutation rate. So in this first figure, we have analyzed the impact of vaccine efficacy. So in the model, 1 minus delta 1 is the vaccine efficacy. So here we can see that if we increase the vaccine efficacy from 25% to 91%, then the cumulative cases will be decreased. The cumulative cases are at lower level from the cases for the case of vaccine efficacy for 25%. So we can conclude that the vaccine efficacy is really effective in reducing the cumulative cases. And then we analyze the vaccine efficacy against mutant strain. So here 1 minus delta 2 is the vaccine efficacy against mutant strain. And if we increase the vaccine efficacy against mutant strain, then cumulative cases will also be decreasing. But there is like no big impact, but still there is impact. But if the vaccine efficacy against native strain, then there is more effective. So this is the results, like according to the model, these results we have. And in the model, we have that 1 minus delta 3 is the immunity against the mutant strain. So if we increase the immunity from 25% to 90%, then the cumulate like over time, and these graphs are plotted for 50 weeks. So over time, the cumulative cases will at a lower level if we increase the immunity. And then this figure shows the impact of mutation rate. So here we have seen that if the mutation rate is increased, so if we increase the mutation rate is little by little, and we have seen that if we increase the mutation rate from 0.01 to 0.09, then there will be higher cumulative cases. And then we have seen the impact of vaccine efficacy on the cumulative deaths. So similar results we have that if the vaccine efficacy is increased from the 25% to 90%, then there will be the cumulative deaths at a lower level. And again, similarly, if the vaccine efficacy against the mutant strain, the vaccine efficacy will be increased against mutant strain, then the cumulative deaths at a lower level. So the vaccine efficacy is important to consider and analyze the impact on the cumulative cases. And then sorry, we have plotted the contour plot of the. I'm sorry, I have to drink some water. So we have plotted the COVID-19 cumulative cases with respect to the combination of two parameters. So this axis shows the vaccine efficacy against native strain, and this x-axis shows the vaccine efficacy against mutant strain. So, like if we increase the vaccine efficacy 0 to 80%, and if we increase the vaccine efficacy against mutant strain from 0 to 80%, then we can see in this region there will be less cumulative cases. So, in order to reduce the cumulative cases, the both vaccine efficacy should be high. But from this figure, we can also see a wondering result here. See that if the vaccine efficacy against native strain is lower and the vaccine efficacy against mutant strain should be higher, then there are more cumulative cases. So this result is indicating that the in order to reduce the cases, the vaccine efficacy against native strain should be higher, and this is important. And here we have analyzed the impact of the immunity against native strain, and here new one is the mutation rate. So from this figure, we can easily see that if the mutation rate is low and the immunity against the mutation rate is low, then there will be higher cumulative cases even for the lower mutation rate. So in order to reduce the cumulative cases, the immunity of already recovered individuals should the immunity against mutation rate should be high. And from this figure, we have analyzed that this is 1 minus delta 2 is the immunity against mutant strain, and this is the mutation rate. So in order to reduce the cumulative cases, we can even for the high mutation rate, the vaccine efficacy should be high. But if the rate is low, then we can see that the if the vaccine efficacy is high, then the cumulative cases are very high. And from this figure, we have analyzed that in order to reduce the cumulative cases, both the vaccine efficacy against mutant strain and the immunity against mutant strain should be high for this in order to reduce the cumulative cases. And then here we have seen a unique dynamics in the model because of the mutation rate. So we have plotted a infectious individual. These are I1 are the infectious individual associated to native strain, and these I2 infectious individuals associated to mutant strain. So we have plotted these individuals with respect to the mutation rate. Here new one is the mutation rate. So this mutation rate caused a dynamics called endemic bubble. So till this rate, like for this range of the mutation rate 0 to 1, there is a curve only. So we have plotted the maximum value and the minimum value of the infected individuals. And till this rate, the maximum value and minimum value is equal. That means for this rate, the disease is endemic, but this is persisting at a certain level. But in this region of the mutation rate, the maximum individual and minimum individuals are different. That means the disease will oscillate. That means the cases will be higher and then lower, then higher and lower, and the outbreaks will occur again and again for the certain value of mutation rate. Then the disease again become persistence in the environment if there is high mutation rate. So we will see this dynamics again by the time series plot. So this plot is these are the infectious individuals I1 and I2 for the mutation rate in this region. So we have seen that the disease is persisting and both strains are coexisting together for the lower mutation rate. And if we increase them, if we took the value of the mutation rate from this range, then we see that the model is giving the oscillation kind of dynamics. That means that outbreaks will occur again and again. So this kind of, like, if a certain range of the mutation rate, there will be oscillations occur. And then again, if we consider the higher rate of mutation, then the disease will again become endemic, and it persists at a certain level. So here we plotted the total infected individuals. The E1 and E2 are the exposed individuals, and I1 and I2 are the infectious individuals. So we have plotted for the different mutation rate. So here we have seen that if the mutation rate is really high, then this blue curve gives the total infected individuals. Then we increase the mutation rate, then the total individuals will be at the lower level. And then if we consider then new one, it is like from the intermediate value from the endemic bubble region, then the disease will oscillate. And if we again increase the mutation rate as a higher value, if we consider mutation rate is equal to 2, then the disease will again become endemic and a lower level. So this kind of, so that's why I had a title before, like, mutations makes pandemic worse or better. So we can give the answer of that question from here. Like, if the mutation rate will be very high, very very high, like then they, I think uh, people have some immunity against the disease if there are many variant exist. And this is also giving a realistic scenario, because now after 2021 there were no big outbreak and there are many variants exist, and I think people have some immunity and disease is endemic. And before that, the mutation rate was a little bit low, but there were many outbreaks occurs. So this is giving a realistic scenario. So in this way, we can say that mutation rate is better if it is high, but it can be worse if we consider the mutation rate from the endemic bubble region. And then we have done the sensitivity analysis of the model. So the sensitivity, and from the sensitivity analysis, we can conclude that which parameter is most sensitive, and on which parameter we should focus in order to reduce the disease burden. And this sensitivity analysis is done by the partial rank correlation coefficient method. So these are the PRCC bar, and these are the model parameter, and this sensitivity analysis is done for the basic reproduction number for the native strain. So this diagram gives the direct correlation of the model output direct gives the idea of the direct correlation between the model parameter and the model output. So from this figure we can easily see that, so the delta 1 and beta 1 has the high bar, and the nu 1 and alpha 1 are also have the high bar, but these are the negative and these are the positive. So positive B bar means a model parameter is positively correlated with the model output. That means if we increase that parameter, then the model output will also increase. So if we increase the recruitment and transmission rate, then the basic reproduction number will be increased. So in order to reduce the basic reproduction number, we should suppress these parameters. We should suppress the recruitment rate and the transmission rate. So we should apply these kind of intervention strategy or control measure that control these parameters. And also mu and alpha 1 are they negatively correlated? That means if we increase these parameters, that means these parameters will reduce the basic reproduction number. So in order to reduce the basic reproduction number, we should increase these parameters, or we should apply the control measure that suppress these, that increase these parameters. So similar results we have computed for the basic reproduction number I2. And here the PRC, the partial rank correlated coefficient are plotted with respect to the basic reproduction number R2 against the model. So similar results we have computed for the R2, that lambda 2 and beta 2 are high. And in order to reduce the basic reproduction number R2, we should control these parameters, and we should increase these parameters mu and alpha 2. And then we have done the sensitivity analysis for the cumulative cases. So we here we have seen that the infectious rate of the native strain and transmission rate beta 2 is the transmission rate because of the mutant strain. A2 is the infectious rate of the mutant strain, and delta 2 is the disease induced death rate of the mutant strain. So in order to reduce the cumulative cases, we should apply these kind of control measure that suppress the value of these parameters. That means that suppress the value of the transmission rate and the infectious rate and the disease induced death rate. And also is the cumulative death PRCC bar plotted for the cumulative death with respect to the model parameter. So in this figure we can also see that the infectious rate A1, disease induced death rate D1, and the disease induced death rate D2, and the infectious rate and the transmission rate have the high bar. That means we should reduce these parameters in order to reduce the cumulative deaths. And this is the recovery rate of the infectious individual. So we should increase the recovery rate in order to reduce the cumulative deaths. So we have a few conclusions from the model. So from the model, we have analyzed that there is a hope bifurcation. Hope bifurcation means there will be oscillations occur if the endemic equilibrium loses its stability because of the mutation rate. Yeah, and then an intermediate value of the mutation rate leads to oscillation, and the system exhibit an interesting kind of dynamics called endemic bubble. But if we increase the mutation rate at a higher level, then the disease will be persist again in the environment. And we have also computed an expression of the herd immunity threshold that can effectively eradicate the disease in the community. And then this study also demonstrated that a pandemic may be worse due to the occurrence of oscillations for the intermediate value of mutation rate, and outbreaks will occur repeatedly again and again, but better due to stability at the lower infection level with a larger mutation rate. So these are the conclusion of the study. And these are my collaborator of this study, the Dr. Jayaprakash Tripathi, was my PhD supervisor. He's the assistant professor in the Central University of Rajasthan, and Professor Hawan is the professor in the University of Alberta, Canada. And thank you so much.
Thank you. We've got some time for questions here.
Yeah.
If you've got a question, you can either put it in the chat or you can unmute yourself.
There's one in Q&A.
I see one in Q&A right now. I'm just going to read it. This is all very theoretical. One needs to know the parameters for the new variants. Did you attempt to match this to the historical values for COVID-19?
Yeah, so we have done a case study of the model. We have first analyzed the theoretical part of the model, and then we have applied the model to the real life. Like we have done a case study for the here we have done a case study for India, and we have considered two strain of the model. And the model is very general, so it can also apply to any other country.
A question on that. A couple. Can you go though to your page with the your slide with the parameters that you estimated with your MCMC calculations?
Yeah.
So what I'm curious about here is some of these parameters look like they're very, very small numerically. And does that mean that these factors like say beta 1 and beta 2 or even D1, D2 there, that they look like they're approaching zero. So does that mean that these factors are relatively unimportant and therefore that the model might be simpler than it was presented?
No, these parameters are we cannot consider. So we have done the sensitivity analysis by considering these parameters. So we have considered these parameters, and then we have done the sensitivity analysis here.
Right.
See right. So the beta 1 is small, but it is like have the larger impact on the basic reproduction number. And if we consider beta 1 is equal to 0, then like there is no output of the model. Right. So these are the like realistic model parameters values with respect to the case study.
Great, thank you. Okay, a couple of other questions in the chat. First one being, how did you extract the parameters? And if you need a clarification, we can get a clarification here.
How did you extract the parameters? So as I discussed, like some parameter values I took from the literature because we already know the like incubation period of the COVID-19 recovery period. Like the recovery period is for average recovery period is 14 days, and some parameter like the transmission rate and death rates we have estimated from the MCMC method.
Another question, what assumptions have you made regarding the interaction between the native and mutant strains?
Yeah, so we have made an assumption. So from a theoretical study, we know that the alpha variant was more transmissible. The delta variant. So we have considered the case study from March 2021 to September 2021 in India. So as we have seen the data here, where are the data? Like here are the data. So we have considered the data from March 2021 to September 2021. So at that time there were two variants, the alpha and delta was the double time transmissible from the alpha variant. So we have considered beta 1 is equal to beta 2 is equal to 2 times into beta 1, and then we have estimated these values by fitting the data. Because we had these cumulative cases and the daily cases. We did not have the data like how many cases are because of the alpha strain and how many cases are because of the delta strain. So we have considered the cumulative cases.
So I had a question, again, since we don't have anything in the chat here. Going back to your original model, if you could sort of pull yeah, right, exactly. One more slide earlier, I think. Right. So you have this asymmetry here where I'm wondering why you don't have in theory going a transition from R2 to E1.
Yeah, okay. So like the native strain occurred earlier and the mutant strain occurred later. So first the individual like from in if we see in the history of 2022, there was alpha variant occurred and the individual got the infection and then they recovered from that variant, and then the later variant occurred, then the recover individuals from the previous strain can get the infection from the later strain. But after that, the recovered individual will occur, recovered individuals from the mutant strain, and at that time, there was no mutant, no native strain. There will be more and more cases because of the mutant strain.
They're basically saying that this asymmetry is because the original strain sort of fades away.
Yeah.
Okay,
Yeah,
okay,
yeah.
okay. Got it. And similarly, for the same reason, you wouldn't bother to have an R2 to E2 transition because you presume that a new strain has come along.
Yeah,
Okay, I see.
yeah,
Got it.
yeah,
All right.
yeah.
So we have another question here. Thank you, Dr. Sarita, for your great work and excellent presentation. In your presentation, I did not see the hop bifurcation, but I see hop bifurcation in the conclusion. Did you complete the analysis of hop
Oh,
bifurcation of the complex
um,
model?
yeah. So here we have seen the endemic bubble. So and we have seen the oscillation in the model. So that means if we vary this parameter from here to here, then there will be oscillation occur. So whenever the oscillation occur, we call it Hope bifurcation. So there was an Hope bifurcation in the model.
Got it. Very good. Thank you. Do we have any other questions from the audience? So I will actually, somebody just asked the question I was going to ask since we didn't have any other questions, but what are your next steps with this work?
Um, so I think we can do many things in the model. We can propose a three-strain model, like we or three-step to n-step model, and then we can see the dynamics, like what kind of dynamics can occur if we consider n strain in the model. Yeah, so this is the important step. And like if we consider n step and more step, then we cannot do more mathematical analysis of the model. We cannot check the stability, we cannot check the equilibrium. So yeah, that is the thing.
And I'm formulating a thought here, sorry. Just looking at it, sort of wondering, going back to your original discussion about the different kinds of variants and the different ways they were pursued, though, it seems like from a public health point of view, you could argue that certain variants became, right, not every variant of interest becomes a variant of concern,
Yes,
right? And so presumably when you're modeling, you're really talking about the emergence of variants of concern, I'm guessing, right?
yes,
And
yes.
so how does one make that determination in real time?
So like these models are general model, and for the real time, we have to consider the data
Right.
of these variants. Yeah, we have to data and we have to do the data fitting, and then we can estimate the real time parameters, and then we can assess the control impact of control measures.
Because that would seem to be the trick question there is to figure out in advance or as early as possible when something is going to really be a concern versus just a minor blip.
Sorry, I didn't understand your
No,
question.
I'm saying that this seems to be the real question is while it's happening, while you see the emergence of a new variant, you don't know at the time whether it's going to be a concern or just of interest.
Yeah,
And so
yeah,
how
like
so does your work provide any insight into that question?
so like if a variant is like occurring and we do not know about the future, like it will lead an outbreak or not, we do not know. Like it depends on the biological nature of the variant. Like it if whether it is an variant of interest or variant of concern. And I'm also a mathematician, so I don't know like much biology of the variants. But like if the way so I propose the mathematical models and I see the impact of the control strategy based on these data. So I propose models and collect the data, and consider the many control intervention, but we do not know the future. But from the mathematical models, we can estimate the parameters and we can predict the dynamics, but we can predict the dynamics to 4 weeks to 8 weeks. We cannot predict the dynamics after than that,
Sure.
right? So in future, anything can happen. Right.
No, it's definitely a hard problem.
Yeah.
Trying to think about what could be done in that situation to use this, because if you're going to talk about the different vaccine efficacies and all that, the question is, what's the how to use this for planning, and that's a hard question.
Yeah, like in future, if a variant can occur like that can evade the vaccination, there is no impact of the vaccine, then we need to develop another vaccine. We do not know.
Right.
Yeah.
Yeah. Okay. So I think we've got about 2 minutes before the end of the hour. So unless there's any other questions, I'm going to say thank you for your time and interesting talk and giving us some things to think about here in terms of variants and vaccines. So thanks, everybody. And before we go, just to remind everyone that the MIDAS meeting is coming up next month, November 17th and 19th, and we hope to see some of you in Silver Spring. Take care, everybody. Thank you.
Yeah, thank you so much for inviting me. It was a great pleasure to presenting my research to the
Thanks.
audience.
Great
Yeah,
having you.
thanks so much.
Thank you.